we're going to talk about acid-base balance. And for those of you who work in ICUs and do ABGs all the time, help your neighbors. Because I'm guessing there's some people in here who can't interpret ABGs off the top of their head, am I right? Are there a few of you? Okay, all right. So the goal of our body is to keep our pH between 7.35 and 7.45. Our body does not care what the PCO2 is. Our body doesn't care what the HCO3 is. Our body cares what the pH is. That's the goal, is to keep our pH within that narrow range. And when we move outside of that narrow range, our cells don't function very well. And all of the activities of the cell fail. So all the enzyme activities, cell replication, I mean, just everything quits working when the pH moves too far outside that normal range. Now, my extremes here, I don't have a good experience with extremes. I would say probably the lowest pH I've seen is about 7.19. I know. See, that's not impressive at all. Yeah. And upper range, I don't know, 7.55 or something. So what have you guys seen?
6.7.
Oh my goodness. 6.7? Wow. And did the patient survive? Wow. That's pretty impressive. How about up in the upper range? No? Nothing? Acidosis you see more of, yeah, than alkalosis. So, yeah. Okay. So, electrolyte balance is affected, clotting is affected, central nervous system function is affected when we move outside that range. And we're going to talk just a little bit about the oxyhemoglobin dissociation curve too. And we're going to look at bicarbonate and carbon dioxide and the kidneys and the lungs and how they help regulate acid-base balance. So an acid is a substance that releases hydrogen ions, and a base is something that takes up hydrogen ions. And so we have acids and bases that are in our body that act as buffers to try to manage what our acid-base balance is. But the biggest one that we have is the bicarbonate buffer system, and that's this equation, which should look at least slightly familiar to you all, where this is half of it, and let me see if I have the whole thing. Here we go. Let me go back to the other slide and we'll look at the whole equation. But this is part of it, and then phosphates also serve as buffers, proteins, hemoglobin all serve as buffers. Now our pH range is 7.35 to 7.45, which is a little on the alkaline side of the range, right? 7.0 is midpoint of when we're looking at all fluids together. So the body happens to be a little alkaline. But we're going to use 7.4 as our midpoint of normal, not 7.0 when we're talking about body fluids. So here's the bicarbonate buffer system equation. So hydrogen ion and bicarbonate combine in a reversible reaction to form carbonic acid, which can break down in a reversible action into carbon dioxide and water. And so this equation is going back and forth all the time in our body, trying to balance what our body needs. If we have a problem that originates in our lungs, so if we have a respiratory problem, our renal system is going to compensate for that by adjusting our bicarbonate level. It's also going to act on hydrogen ion a little bit, but the primary mechanism is either getting rid of more bicarbonate or hanging on to bicarbonate, depending on what our body needs. That's a fairly slow reaction, but it's unlimited. You can keep pumping out bicarbonate, more and more bicarbonate, and not get to an end of that. But it takes time for your kidneys to make that adjustment. If we have a problem that's a metabolic problem, say we have diabetic ketoacidosis, our lungs are going to respond to try to compensate for that. And they're going to do that by regulating the carbon dioxide that we either retain or exhale. Now, that can happen pretty fast because your respiratory rate can change really fast. But there's a limit to how much CO2 you can retain and how much CO2 you can blow off, right? You can retain CO2. How do you retain CO2? So CO2 is exhaled, right? So if you slow down exhalation or if you hold your breath, you would retain CO2. Can you hold your breath forever? No. So there's a limit to that, okay? And you can breathe faster to breathe off more CO2, but there's a limit to that too. You can only breathe so fast. So the pulmonary compensation is fast, but it's limited in what it can do. And our goal is to maintain the ratio of bicarb to carbonic acid, so base to acid, at a ratio of 20:1 to get our pH to stay within that 7.35 to 7.45 level. So we don't care if it's 20:1, 40:2, 80:4, whatever it is, it doesn't matter as long as the ratio is there. That's why it doesn't matter what our CO2 is, it doesn't matter what our bicarb is, it matters what the ratio is. So we just talked about this. The pulmonary system compensates for metabolic disorders, and there are chemoreceptors in the carotids that detect the amount of bicarbonate that's present and adjust the respiratory rate really quickly as needed, but there's a limit to how much we can change our respiratory rate. And for the renal system or the metabolic system is what compensates for respiratory disorders, and it takes a little while for it to get started, but it's unlimited in its ability to do that. So here's our normal range. pH does not have units associated with it. It's a calculated number. It's based on the logarithm of the hydrogen ions, something or other. You could look up those formulas. This is the downside of having your lectures posted on iTunes, so somebody's going to hear me say that, which is a little embarrassing, but that's all right. So pH is 7.35 to 7.45. The arterial pressure of carbon dioxide in arterial blood vessels is 35 to 45 millimeters of mercury. And if you just have never noticed that, these numbers are the same, 3.5, 4.5, 35 to 45, to kind of help you remember that. And then the bicarbonate is 22 to 26 milliequivalents per liter. It's measured in milliequivalents because it's an ion like sodium or potassium is. The CO2 we're going to look at as if it's an acid. The bicarb we're going to look at as if it's a base. So if you have more CO2, you're more acidic. If you have less CO2, you're more alkaline. If you have more bicarbonate, because it's a base, you're alkaline. If you have less bicarbonate, you're more acidic. Okay. So there are many, many ways to interpret arterial blood gases. I like this one because to me it's really easy, and I don't have to remember, well, does the CO2 go up or does the bicarb go down or what happens? I don't have to remember which one goes which way. I just go through these steps and it tells me what the abnormality is. So in step 1, we're going to label our values as either acid, base, or normal. Now at this step, the pH cutoff is 7.4. So if it's 7.39, we're going to call it acid, even though that's normal, right? A 7.39 pH is normal, but we're going to call it acid in this step only, because it's less than 7.4, okay? But here we have a pH of 7.28, so that's low. And so if the pH is low, we're acidic. The CO2 is 65, so that's high, and because CO2 is an acid, if it's elevated, we're going to say that's acid. The bicarb is 24, that's within normal range, so we're going to call that normal. So on these two, on the PCO2 and the bicarb, we're not going to use the midpoint. It's only on the pH that we're going to use the midpoint to decide if it's acid or base or normal. Okay? So then in step 2, we look to see which matches the pH. So in this example, it's the CO2 that matches the pH. That means it's a respiratory problem. The underlying problem is a respiratory problem. Okay? Do you get that? So you label them all, and then you find which one matches the pH, and that's the origination of the problem. So in these examples, what's 7.32? Acid. 53? Acid. Bicarb? Alkaline or base. I use base so that I label some with an A and some with a B. So this is acid, acid, base. So the two that match here are the CO2 and the pH, so this would be a respiratory acidosis. Okay. How about this one, 752? Base, acid, base. So which two match? the bicarb and the pH. So we have base, acid, base. So this is a metabolic alkalosis. Okay? That's step 2. Oh, there they are right there. Did I take that off yours? You can label them though yourself, right? You don't need that up there to label them. Okay, now the next step is to decide if the body's compensating for this abnormality yet or not. So if the compensating value has changed, so back here in this example on the left here, this is respiratory acidosis, so the compensating value is the bicarb, right? The original problem is the CO2, so the bicarb. Has it moved outside of normal range? Yes, it has. So the body is trying to compensate. It's making an effort towards compensation. Is the pH within normal range? No. So it has not achieved compensation yet. It's moving towards it, but it's not there yet. So we would call this a partially compensated respiratory acidosis. Okay. And so, again, if the compensating value has changed, but the pH is not normal yet, it's partially compensated. If the pH is back within normal range, that means that we've got back to that 20-to-1 ratio. So again, it doesn't matter what the individual CO2 and the individual bicarb are. Like in this example here on the right-hand side, oh, that pH is not within normal range, never mind. We'll look at one of those. So once the pH is back in normal range, that tells us that we're back at our 20-to-1 and we don't care what the individual PCO2 and the individual bicarb are. So here are some examples. So let's walk through those. And if you listen back to this, I'm going to put the microphone on pause, on mute. All right. So this first one is the pH acid or base, or normal. Acid, CO2, acid, bicarb. So what do we call this? Uncompensated respiratory acidosis. Those darn kidneys haven't done a thing yet. They're just hanging out there. 752, base. 37, normal. 32, base. Uncompensated metabolic alkalosis. 731, acid. 39, normal. 20, acid. So uncompensated metabolic acidosis. 730, acid. 49, acid. 30, base. Partially compensated respiratory acidosis, right? So the bicarb is trying to help, but we haven't got the pH back into the normal range yet. So it's not there. It's partially compensated, but not fully compensated. 742, well, we're going to use alkalotic or base. 7.4 is the cutoff. 41, 25. So what is this? Normal ABG, okay? Sometimes people have normal ABGs. So you still have to name the pH in the first step as either acid or base, and then you go from there. Now, somebody asked about venous CO2. So, you know, when you get, if you just get electrolytes, you hardly ever see this anymore, but you get sodium, potassium, chloride, and CO2. Or if you get a panel, you get CO2 on it. That's venous CO2. Remember, that's not arterial CO2. So it's different from the arterial blood gases. And I can never remember off the top of my head. I have to always figure it out. And I would encourage you to do that with all of this stuff. I think I've said this before. Don't memorize a bunch of stuff. See if you can figure it out. So what I have memorized is that in ABGs, the PCO2, if it's elevated, means respiratory acidosis. And if it's decreased, it means respiratory alkalosis, assuming the bicarb hasn't changed. Okay, if we're just looking at a change in CO2, that's what it means. The venous CO2 is the opposite. So the venous CO2, if it's elevated, it's metabolic alkalosis. And if it's decreased, it's metabolic acidosis. And it's because what this is actually measuring, even though it's called CO2, it's really measuring the bicarbonate content. Now, don't ask me whose idea that was. It wasn't my idea. If I had been in charge, it would not have been that way. But that's the way it is. So the venous CO2 is just opposite of what the arterial CO2 is. Yes? But you're not measuring, this CO2 is not measuring the partial pressure of CO2, which is what the PCO2 is. It's measuring the content of the CO2. Now, arterial blood, I don't think it should be any different. I don't know that the value would be different. Now, if you're measuring the partial pressure in arterial blood versus the partial pressure in venous blood, then there's a difference because we have CO2 and oxygen moving in and out of the tissue and into the bloodstream. So that's different. But I don't think that the arterial value of CO2 is different. Not PCO2, but just CO2. Does that make sense? Okay. Anybody know anything different?
At least in practice, the bicarb on the gas usually matches the CO2 on the lights when they're drawn on the arterial line.
Okay.
Why, I have no idea.
Yeah. Well, because that's what they're reflecting each other. So, okay, good. Thank you. All right. So we just talked about all those answers. Okay, so let's talk just a little bit about these different conditions and how we get them and what we do about them. So respiratory acidosis is because our alveoli are not getting ventilated enough. And so we have CO2 staying in our bloodstream, being absorbed into our bloodstream, not being blown off out of our alveoli. The signs and symptoms of acidosis, whether it's respiratory or metabolic, acidosis is a CNS depressant. So it's going to cause lethargy, sedation, maybe confusion. People are going to be slowed down with acidosis. And then we'll also see some dysrhythmias from this, whether it's metabolic or respiratory. So the compensation is that the kidneys are going to try to retain bicarbonate. That's going to take a little while. And the major treatment for this is to improve ventilation. Have people use an incentive spirometer, have them get up and ambulate. Maybe giving them enough pain medication so that they can do deep breathing. Now, pain medication can depress the respirations, so you have to find a balance there. But if they're not deep breathing because it's painful, then we've got to treat that so that they can do what they need to do to get the air in and out. So here's an example. By the way, the other examples on this slide are not actually combinations that you would necessarily see. They're just numbers I pulled out of the air. There's actually an equation that would tell you, if you know the pH and the CO2, would tell you what the bicarb is. It's called the Henderson-Hasselbalch equation. And I didn't use that to come up with all my examples. I just made them up. Here, these are actual values that you would see. So in the right relationship to each other. So in the first set of values in the uncompensated column, we have an acidotic pH, an acidotic level of CO2, and a normal level of bicarb. Then as the body starts to compensate, what it does is it retains bicarbonate, because that's how it's going to compensate for that respiratory problem. Why doesn't the PCO2 change? Because if it coulda, it woulda. If it could have changed to correct the problem, it would have done that. But it couldn't. That's why the problem exists. So the kidneys have to jump in and try to compensate for that. That brings the pH up a little bit, but not yet into normal range, until finally we retain enough bicarbonate that we get our pH back in normal range. So here again, we don't care that the PCO2 is abnormal. We don't care that the bicarbonate is abnormal. We care that the pH is normal, because that's our 20-to-1 ratio. Respiratory alkalosis, increased ventilation, blowing off too much CO2. Things like stress and anxiety. In OB, you see that in laboring women, hyperventilating. You see it in the emergency department. People come in anxious. So signs and symptoms, CNS irritation. So people are tremulous and anxious and revved up because of that. And we also see dysrhythmias, whether it's acidosis or alkalosis, it can affect the heart. Here again, the compensation is from the kidneys, where they excrete more bicarbonate. And the treatment here is to treat whatever the underlying cause is, if we can identify that. Now, a lot of times you see that people jump to breathing into a paper bag so that they rebreathe their CO2 and bring their CO2 level up. We shouldn't do that unless we're in a monitored setting with backup to treat the patient in case they stop breathing because we gave them too much CO2. So you want to be careful about that. And if we can identify what the underlying cause is, let's treat that. Then their hyperventilation will go away. Okay. So here our pH is elevated, reflecting alkalosis. The PCO2 is low because we're blowing off too much CO2. And in the first stage, the bicarbonate is normal. Then we begin to excrete more bicarbonate until our pH comes down into the normal range again. Metabolic acidosis. We can get organic acidosis, where our body is producing excess acid, hyperlactatemia, diabetic ketoacidosis. So hyperlactatemia is too much lactic acid. So when do we get lactic acid? Anaerobic metabolism, and also in sepsis, we see a buildup of lactic acid, lactate. And then in diabetic ketoacidosis, we have production of ketones, which are acids. So both of those increase the acid load in the body. Or we can have a deficiency of bicarbonate, which we get sometimes with renal failure. Now, a couple of things happen in renal failure. Number one, we can't excrete hydrogen ion, but we also can't make as much bicarbonate, and so we end up with acidosis. The signs and symptoms are those signs and symptoms of CNS depression. And then treating the underlying cause, again, trying to figure out what's going on and reversing that is the best treatment. So here we have a pH that's low, reflecting acidosis, a normal CO2, and a low bicarbonate, again, reflecting acidosis because bicarb is a base. So if we don't have enough of it, we're acidotic. And gradually, our respirations, what are we doing here? Blowing off CO2. Blowing off CO2. In diabetics, what do we call that? Small respirations. Okay? Slow, deep respirations, or not slow necessarily, it could be fast, deep respirations, blowing off CO2. Now, the anion gap is something that helps us pin down what the cause of the acidosis is. So have you all seen anion gaps on lab reports? Have you used them before? See, this class is that's worth the price of admission right there, right? So what happens is, I think I have a picture of it here. Let me skip ahead to the picture and we'll go back there. So we know that sodium is our major extracellular ion, and we know that for every positive ion there has to be a negative ion, right? So our chloride at normal level is about 104 milliequivalents, bicarbonate 24 milliequivalents. But there are more anions there, we just don't measure them, but we know that they're there. That's called the anion gap, okay? So there's a gap between what we measure and what we know must be there. So a normal anion gap is around 12. We've got that on another slide I'll show you. Now, if you have metabolic acidosis, the anion gap may change or it may not change. And some kinds of acidosis cause the anion gap to change, and some kinds of acidosis don't cause it to change. So we have to know the patient has metabolic acidosis first. And once we've identified that, then if they have an anion gap, it'll lead us to some causes, and if they don't have an anion gap, it'll lead us to other causes of metabolic acidosis. So here's an example where the patient has metabolic acidosis in the middle here, where the chloride is elevated at 114. The bicarb is low, so if you have acidosis, your bicarb might be low. But the anion gap hasn't changed. Okay? These two have changed. The bicarb and the chloride have changed, but the anion gap hasn't changed. In the third example here, we have metabolic acidosis with a high anion gap. Our sodium is still 140, our chloride is normal, but our bicarb is even lower. And so we have a bigger gap here, a bigger anion gap. So let's go back now and look. So the anion gap helps us account for those unmeasured anions or negatively charged ions, and the concept here is electroneutrality. We just know that if there's this many positive ions, there must be this many negative ions. So most of the unmeasured ions are plasma proteins. And so you can use this equation here to figure out what it is, but you don't have to do that because they're going to give it to you on a lab report. They're going to tell you what the anion gap is. And the normal range depends on the lab, but it's typically somewhere between 8 and 16 milliequivalents per liter. And what we're concerned about is if it's elevated. So we're looking at people who have metabolic acidosis. Do they have a normal anion gap or a high anion gap? And so we can look and see that if people have diabetic ketoacidosis or lactic acidosis, they have a high anion gap. Where if they have acidosis because they've lost bicarbonate through their GI system, they have a normal anion gap. And there are other causes too, obviously. But so a patient comes into the emergency department, they're not able to communicate. We assess them and determine that they have metabolic acidosis, but we don't know anything about their history. Well, if they have a high anion gap, we're going to look for different things than if they have a normal anion gap. So that's the whole point of that, to help us direct our pathway towards what kind of causes of metabolic acidosis we're going to look for. Does that make sense? Okay, then the last one here is metabolic alkalosis. And this actually, although we say we don't see this much, it's according to the literature, the most common acid-base disorder in hospitalized patients. And we can either have an excess of bicarb or a loss of acid. And when we have depletion of chloride, and we mentioned this earlier, we get retention of bicarb, and so we continue to have alkalosis. So if you have a patient who has metabolic alkalosis and their chloride is low, until we correct their chloride, they're going to continue to have alkalosis because they can't excrete bicarb until their chloride is back up to normal. Okay. Diuretics can cause this, and hypovolemia can cause it as well. So same thing, until we correct their volume status, their metabolic alkalosis probably isn't going to go away. Signs and symptoms, evidence of CNS stimulation, decreased level of consciousness, seizures, those kinds of things, but also problems with ventilation and oxygenation as well. Now the lungs tend to retain CO2 if they can do that, and then looking at the urinary chloride level can help. And if they're excreting chloride, then we say it's chloride resistant, and we have to correct that, or else we can't correct their metabolic alkalosis. So here we have a pH that's elevated, demonstrating alkalosis, 7.64, and a high bicarbonate and a normal CO2. And we gradually retain CO2 to try to correct the pH. But again, you can only slow down your respiration so much. So you have to be watching for hypoxia in these patients because they're hypoventilating. Treatments, replace the chloride. We can give H2 blockers to prevent alkalosis, especially when patients are getting NG tube suctioning, and treat the underlying cause, especially if their chloride is a problem. Oh, there's the same picture again.